Assalamu alaikum. This is an overview of the commonest 5 vocal folds benign lesions, especially suited for ENT trainees and students. This is part 1 of 2 lectures. This is a cross-section of the free margin of the vocal fold, showing the covering epithelium, the superficial layer of the lamina propria, the elastic intermediate layer of the lamina propria, and the collagenous deep part of it, together with the deep core of the vocal fold layers, the thyroarytenoidus muscle, the vocalis part of it. The vocal fold polyp is a benign mucosal lesion of the membranous vocal fold free margin. It results from phonotrauma in most cases. The generated shear forces from coughing or voice misuse or abuse or a valsalva would result in a microhemorrhage in the superficial layer of the lamina propria and vascular leak of things like serum or certain blood proteins, including hemosiderin, for example, into the lamina propria. This would form an organized soft tissue swelling within the superficial layer, and this would stretch the covering mucosa and protrude into the airway. The polyps would differ from vocal fold nodules in that the origin of the pathology is in the superficial layer of the lamina propria, not the basement membrane of the vocal fold epithelium. The site of involvement is not necessarily in the site of maximal voice strain in the mid part of the membranous vocal fold. It can be anywhere, including the anterior commissure, superficial or the inferior parts of the vocal fold, but commonly in the middle part of the membranous vocal fold. Vocal fold polyps are mostly, but not exclusively, unilateral. They affect a localized area of edematous polypoidal changes superficial to the vocal ligament on the free edge of the vocal fold covering. It may also occur sometimes on the superior or the inferior surface of the vocal folds. It's more common in men, in smokers, and in the young and the middle age groups between the age of 30 and 50 years. The pathogenesis of vocal fold polyps is usually due to an acute phonotrauma, and patients can usually point the dysphonia to a specific event or a time. This acute event would rapidly lead to changes such as leakage in the interstitial fluid of the vocal fold, hemorrhage from the engorged blood vessels, and deposition of serum and certain proteins, including fibrin and hemosiderin. This would organize later, and this organization of the vascular injury will result in an associated inflammatory process and attempts at repair. The site of the injury is in the superficial part of the lamina propria. The phonotrauma can be things like aggressive cough during a viral illness when the vocal folds are already congested, or phonotrauma such as shouting or at a sporting event or screaming. This can all lead to the phonotrauma necessary to induce the formation of the polyp. There are several subtypes of vocal fold polyps, ranging in number, shape, color, and position, but all sharing the same pathology and pathogenesis process and mostly treatment modalities. Perhaps the most common of these subtypes is the hemorrhagic polyp, which is usually shaped like a half sphere and is usually associated with a dilated blood vessel on the surface of the vocal fold. It's positioned on the free edge of the vocal fold, and it can sometimes be on the superior surface or the inferior surface and have either a bluish or a pinkish color. It's mostly unilateral, but as you will see later, it can also present as multiple polyps or even bilateral polyps. The other subtype is the pedunculated fibrous polyp. This starts as a hemorrhagic polyp, but if left long enough, the microhemorrhage and the exudate into the superficial part of the lamina propria would be absorbed, leaving about a paler and a smaller polyp. The color could be translucent and has variable amount of superficial keratosis due to the long duration of the polyp and the frequent vibration, the effect of frequent vibration of the vocal cord. This will continue to have the feeding vessel of the vocal fold, which becomes much more clearer during surgery. You could see the vessel going into the base of the polyp. It would form this fibrous mass on the edge of the vocal fold with some keratinization on top, and sometimes it may resemble a nodule, and we'll come to the ways of differentiating this at a later part of this presentation. A third subtype of vocal fold polyps is the gelatinous and gray polyps. They may have a different pathogenesis. Occasionally, on the contralateral vocal fold, there may be a pathology such as a vocal fold sulcus or a mucosal bridge that leads to vocal fold stiffness and disordered vibratory pattern. This would make it more likely for the other vocal fold to have damage over a longer period of time, and this may result in the polyp formation. In addition, vocal fold polyps can also be bilateral, as we can see here, affecting both vocal folds, not necessarily equal, and they can vibrate with different vibratory patterns and frequency and amplitude due to the mass effect of the vocal fold polyp. The effects of asymmetric mass loading of the vocal folds is shown here on this patient who have bilateral vocal folds polyps, one of them much larger than the other with a bigger mass. You could see the vocal fold vibrations on the vocal fold with the smaller mass is much more quicker, with a higher amplitude and more complete wave than the vocal fold which is harboring the larger mass. In general, the mass loading side would have a reduction in the vibratory amplitude and the propagation of the mucosal wave that results in asymmetry of the vocal fold vibrations. So in summary, the voice quality of the patient with a vocal fold polyp and the presenting complaint will depend on primarily the mass of the vocal fold polyp, the effect of the mass, the effect of the polyp on incomplete closure of the vocal folds during phonation, and whatever secondary compensatory mechanisms the patient may have developed, like increased muscle tension, for example, and any other associated problems like vocal fold stiffness in the hemorrhagic polyps. This would result in some vibratory characteristics. There will be lower fundamental frequency of vibration and asymmetry in the vocal fold vibration, and occasional phase difference between the two vocal folds and aperiodic vibration. The patient's voice in the early stages may be quite normal. There may be some mild roughness and occasionally a strained voice. Patient may describe voice fatigue due to the need to increase the subglottic pressure to drive oscillation and some lowering in vocal pitch. The threshold pressure for phonation is usually elevated, and there may be some cutouts in the speech, like voice breaks, and some loss of the range of the voice. The dysphonia may occur at specific range due to voice breaks and to the roughness. On examination, sometimes if the vocal fold polyp is small enough and positioned on the undersurface of the vocal fold, it may be difficult to see it clearly. In these cases, it may be necessary to ask the patient to phonate loudly. This loud phonation would exaggerate the phase difference between the upper and the lower lips of the vocal fold during phonation, and can show the vocal fold polyp on the lower lip when they are moving inwards, while the upper lips of the vocal fold are still open. A vocal fold polyp may form a reaction on the contralateral vocal fold due to the effect of phonation. The contralateral vocal fold reaction is called a contracoup lesion, and if this is keratinized, sometimes the appearance may resemble bilateral vocal fold nodules rather than polyps. Very occasionally, a vocal fold polyp may have components of both a vocal fold nodule and a vocal fold polyp, in that the epithelium itself would be thickened together with injury of the basement membrane, and the superficial part of the lamina propria may also have hyaline deposits and edema. These hybrid lesions between a polyp and a nodule have sometimes humorously been termed podules or nolyps. The distinction has some clinical importance in that obviously these lesions would require, if diagnosed as a polyp with thickening of the epithelial lining, the best treatment would be surgery rather than attempts at prolonged voice therapy. Occasionally, it may be difficult to differentiate between vocal fold polyps with a contralateral reactive lesion and vocal fold nodules. Generally, vocal fold nodules are usually, but not always, in the mid-membranous part of the vocal fold, and they would be surrounded by an area of erythema and edema, and they would rarely have a distinct feeding vessel, whereas polyps can occur anywhere along the length of the membranous vocal fold, usually have a feeding vessel, and the surrounding area appears normal in pattern and in color, and it has its own characteristic vibratory pattern with a degree of asymmetry in the vibration, and this can differentiate between a polyp and a nodule. We now move to vocal fold polyp management. In general, a vocal fold polyp is a surgical condition, although very rarely polyps can shrink spontaneously or even be coughed up. Preoperative voice therapy is still, however, important in teaching patients some coping strategies and preventative advice, and also in easing their symptoms before surgery. Even for clearly obvious surgical lesions like pedunculated polyps, the preoperative voice therapy would help clearing the functional component in the patient's condition, such as muscle tension dysphonia, that was perhaps the underlying trigger for the development of the polyp in the first instance. It's also important to treat any concomitant inflammatory condition, but generally speaking, voice therapy is unlikely on its own to result in resolution of most polyps. Prompt surgical intervention would be required in cases of lesions that are large enough to affect the airway patency, and in cases in which malignancy may be suspected. For the majority of patients with vocal fold polyps, the treatment would be microlaryngosurgery. The general principles are preservation of all the normal mucosa, the management of any small ectatic vessels, particularly those feeding the polyp itself, obtaining a straight vocal fold edge and adequate vocal glottic closure during phonation, with minimal resection of the lesion and a minimal epithelial defect. And of course, care should be taken not to expose or damage the vocal ligament the superficial part of it would be the intermediate layer of the lamina propria. Cold steel microlapryngosurgery would start with holding the polyp with an atraumatic forceps, and using curved scissors the base of the polyp would be incised. This would ensure removal of the polyp with minimal epithelial defect, avoiding any exposure and injury to the vocal ligament. And then injection of the site of the resection with steroids would help to reduce the post-operative inflammatory reaction and any fibrosis. The same surgical principles would be applied if laser is used in the microlapryngosurgery, usually with jet ventilation. A spot size curved is about 1.5 millimeter in length and 1 millimeter in penetration, using 10 watts in a single pulse mode of 0.05 pulse duration. The base of the polyp would be incised and the polyp itself would be removed with minimal epithelial defect, and again the area would be injected with steroids to decrease any post-operative inflammatory reaction. The feeding vessel to the polyp would need to be cauterized during the process as well to prevent any possible recurrences. We now move to vocal fold nodules, Singer's nodules. Vocal fold nodules are benign nodular swellings on the medial edge of the vocal fold covering epithelium. They are tiny, usually less than 3 millimeters in diameter, and they are classically located at the junction of the anterior and the middle thirds of the vocal folds, that is to say, the mid part of the membranous vocal folds. This is presumably the site of maximum excursion and forceful contacts between the vocal folds during phonation, and is the site for maximum phonotrauma. There is usually a history of vocal abuse and high professional vocal demand. Nodules, age and gender. Nodules are commonly seen in children, adolescents, and middle-aged females. In the pediatric group, the incidence is higher in boys. On the other hand, in adults, they are much more frequently seen in females. This is related to the higher fundamental frequency of vocal fold oscillations. The higher frequency of the vocal fold oscillation determines the absolute acceleration and deceleration forces, and when these are increased, they would also be increased in children and the female speakers. Nodules would disappear spontaneously in boys with the natural reduction in the fundamental frequency after puberty, but the females' nodules in adolescent and children would persist into early adulthood, and they are very much more commonly seen in females, particularly under the age of 30. This is a cross-section of the vocal folds showing the 5 layers, starting with the covering epithelium, which is anchored to the superficial fluid part of the lamina propria, followed by the intermediate elastic part of the lamina propria and the deeper collagenous part of it. And finally, the core of the vocal fold is formed of the muscle part of the thyroarytenoides, the vocalis muscle. The epithelial cover of the lamina is anchored to the superficial part of the lamina propria by a basement membrane zone. This is in its part formed of 2 layers. One of them, the more superficial, is the lamina lucida, which is low in density and lies next to the basal epithelial cells, followed more deeply by the lamina densa, which has type 4 collagen fibers anchoring the epithelium to the superficial layer of the lamina propria. This is an area that is subjected to high levels of stress and shearing forces Imagine that this area would be subjected to few hundreds of times to movement during oscillation, and all these forces and shearing effect could cause injury to the epithelium and the underlying superficial layer. The basement membrane zone functions are basically to attach the epithelium to the superficial layer by collagen fibers, and also it is helpful and essential in the repair and the maintenance of the epithelium if it is subjected to any injury. Over time, with chronic disruption of this layer, this may lead to the formation of vocal fold nodules. So the stages again are phonotrauma in this segment, because of the excessive stress on the mid-membranous part of the vocal folds, causing injury to the superficial layer of the lamina propria and the epithelium, followed by tissue remodeling and scarring, resulting in the development of the tiny nodules. Abnormal vibratory patterns are more injurious and damaging than high-intensity vibration, and this would explain the higher incidence of nodules in singers who are untrained compared to formally trained performing artists. And histologically, this is manifested as epithelial hyperplasia with thickening of the covering epithelium, thickening of the basement membrane zone, hyalinization and edema, and abundant fibrin and organized collagen in the basement membrane and the superficial part of the lamina propria. This is generally acellular, and immunohistochemical studies would confirm that the thickened basement membrane zone would be rich in fibronectin. Cases with vocal fold nodules present clinically because of their voice problems. The principal defect would be reduced vocal fold oscillation. This is due in part to the increased stiffness of the vocal folds, but also may be due to a mass effect if the nodules are big. There is also an element of incomplete closure of the vocal folds during phonation, given this hourglass appearance. This is characteristic. This would lead to a voice that is husky and breathy, and also to voice fatigue when their symptoms worse on prolonged voice use. This is sometimes associated with tenderness in the neck around the larynx, some discomfort in the neck or throat during phonation. The voice would also be deeper in pitch, and sometimes there may be voice breaks, particularly at the higher end of the range of the voice. In singers, it may start with the singers complaining of inability to reach or sustain the higher notes of their range, and later they may develop pitch break and also voice fatigue. And then the clinical examination. There is always a history of voice abuse or overuse. The laryngeal examination may show the classic picture of bilateral symmetrical vocal fold nodules in their mid-membranous vocal fold position, but it may also show a variety of other shapes, locations, size, and symmetries of the vocal nodules. It does not have to be always in the mid-membranous portion of the vocal folds. In some subjects, you may even have multiple nodules, and you would see the mucous strands across these pairs of nodules. This is a variety that is not usual, but it can be seen. You may also notice asymmetry in the shape of the nodules. One side would be bigger than the other, or one side would be more pointed and the other would be flatter. Or you may even see the pair of nodules in a different position, a bit more anterior. This is typically seen more in singers, particularly in sopranos, who use higher frequencies to produce the singing voice, and this would be the site of the maximal phonotrauma. And of course, sometimes there may be differences in the color of the nodules itself. It may be paler or a little bit more congested if it is early in its early stages. Prenodules, or a nodular diathesis, refers to very subtle changes at the vocal fold edges, so subtle that the lesion is not called a nodule yet. They appear as a mucus collection in the presumed site of the nodule, and there is scant evidence of any mass or stiffness of the coat apart from collection of mucus in there. And there is also an incomplete closure of the glottis during phonation, giving the hourglass appearance. Stroboscopy may not show any changes in the vibratory amplitude or the mucosal wave, but on soft phonation there may be a reduction in the vibratory amplitude and the mucosal wave. The mucus, you could see the collection may swirl around the rough area where the nodule is going to start and form a turbulent collection. And then early nodules would form with are fusiform in shape and have an appearance of having fluid inside like edema. These are the early soft vocal fold nodules that they respond much better to voice therapy, and rarely surgery is indicated. Juvenile type of nodules are usually soft nodules. They have the fusiform shape and they give the appearance of having edema fluid inside. In boys, they respond very well to voice therapy and may resolve spontaneously with puberty, with the reduction in the vocal fold oscillation rate and the change in the size of the larynx. The juvenile type in girls may persist into adult life. These are the hard and mature vocal fold lesions in action, with evidence of mass effect in addition to the stiffness of the vocal fold edges, and the nodules may be seen to rock back and forth in the vibratory cycle. There may still be a symmetric reduction in the vibratory amplitude and the mucosal wave. In Singer's nodules, the nodules are usually a bit more anterior in position, not in the usual mid-membranous portion, due to the high-pitched singing, particularly in sopranos, with preferential vibration of the anterior portions of the vocal fold. This is where you would expect the phonotrauma to happen. The nodules are also usually smaller in size and more prominent and white in color, reflecting a more superficial response to the phonotrauma. Differentiation between a hard versus a soft vocal nodules is useful in assessing the prognosis, the likelihood of response to voice therapy alone, and on deciding whether surgery is required or not. Hard nodules on steady phonation will appear to have a rocking movement separate from the mucosal wave of the vocal fold margins, due to the mass effect on top of the stiffening effect on the vocal fold edge. The hard nodules will have a greater reduction in the amplitude of the mucosal wave. In patients with hard vocal fold nodules, the mucosal wave will propagate sometimes around rather than across the vocal fold nodules. They may also have a hyperkeratotic appearance, like in this. And lastly, hard nodules will have a more apparent hourglass appearance than in soft nodules. Management of the vocal fold nodules. A Cochrane review previously concluded that there were a little evidence to base reliable conclusions upon about the comparative effectiveness of surgery against non-surgical intervention for the nodules. We know that vocal fold nodules may settle spontaneously, particularly in boys after their puberty. And once the demand on the voice, the extra demand, returns to normal. If the nodules are not causing significant voice problems, the general advice is that they should be left alone. They should be treated conservatively. And the first thing is that contributory factors such as reflux or allergy of the upper respiratory tract should be appropriately treated. Also, any psychological issues should be addressed. But in a very small number of patients, surgery may have to be considered. This should virtually never be performed without adequate trial of expert voice therapy. But if the symptoms and the vocal fold nodules itself is refractory to maximal and compliant voice therapy, this is one indication for considering surgery. Also, mature nodules that may be better managed by surgery rather than prolonged voice therapy, or nodules that have atypical features such as asymmetric nodules, irregular nodules, or suspected features. When a decision is made for surgery, microlapryngosurgery with excision of the nodules should aim at preserving the normal mucosa and keeping a straight vibratory edge, a straight vocal fold edge, and adequate glottic closure with minimal resection and raw surface on the vocal fold surface are very important. It's also important not to expose or damage the intermediate layer of the lamina propria. The initial success rate after surgery may be up to 95% of the cases, but recurrences within 5 years follow-up or so may be as high as 19% if the patient reverts to the old vocal use, abuse, or misuse. The outcome of laser resection is comparable to cold steel surgery, and it is the surgeon's choice to select the modality of the surgical intervention. On microlaryngosurgery, it should be remembered that the superficial layer of the lamina propria may be thinned and scarred. The center of the vocal fold nodule is grasped with a non-traumatizing forceps and pulled medially, and then a straight incision is made on the vocal fold epithelial cover, and curved scissors are used to minimize the chances of secondary notching and to minimize the amount of excised epithelium. The two vocal folds can be dealt with in the same fashion at the same setting, but if the nodules are very anterior, care must be taken to prevent any raw surface close to the anterior commissure. Laser microsurgery may be used with jet ventilation, curved 1.5 mm beam length incisions, 1 mm penetration with a 10 watt power, single pulse mode, and a pulse duration of 0.05 seconds. This will ensure minimal damage to the vocal ligament and minimal excision of the vocal fold mucosa. And then a pledget soaked with adrenaline would be used to clean the area, and the second side would be done in the same way with curved incisions and single pulse mode. Again, minimal amount of resection and minimal amount of heat dissipation to the lamina propria. And then injection with steroids would be helpful to decrease the inflammatory process and the scarring of the site of the surgery and decrease any recurrence. And a proper postoperative voice therapy is essential in maintaining a healthy phonatory behavior and minimizing recurrences. When the recurrent cases were analyzed, more than half of the recurrent cases did not have a proper postoperative voice therapy. Among the recurrent cases, less than a fourth of the patients only had postoperative therapy, in a study of a median follow-up period of 9.5 years. It was also found that patients who are treated with an integrated approach team, including surgeons and phoniatricians and speech therapists, had greater chances of a better outcome compared to those who underwent isolated voice therapy after surgery or underwent surgery alone. Next, we go through Reinke's edema and vocal fold polypoid degeneration. Reinke's edema is a swelling of the vocal folds that is benign, diffuse, and sessile due to the excessive deposits of glycoproteins and hyaluronic acids in the superficial layer of the lamina propria. These deposits would stay in place in the vocal folds due to the poor lymphatic drainage of the vocal folds. It's bilateral in as much as 85% of the cases. It's fairly common, being the third most common disease affecting the vocal folds after vocal fold polyps and chronic laryngitis in one large series. A large meta-analysis had showed no difference in the rate of affection between males and females, with almost similar rates, but females are more likely to seek medical help because of the effect of lowering of the pitch on their voice. The usual age is between 40 and 60 years, but it can affect teenagers or the very elderly. The exact etiology of the condition is yet to be identified, but it's known that it almost exclusively affects moderate to heavy smokers. Other contributing factors include vocal strain, laryngopharyngeal reflux, and it can be a concomitant feature in hypothyroidism. Klein-Sasser had noted that the accumulation of the fluid in the subepithelial space of the lamina propria can be the result of the changes in the microvessels permeability in the superficial part of the vocal fold. This was later also suggested with electron microscopic studies that had showed changes in the vessels of the submucosal lamina propria that may lead to the condition of Reinke's edema. The specific pathological features of Reinke's edema is accumulation of deposits in the subepithelial layer, these lakes of deposits in the superficial part of the lamina propria, and changes in the microcirculation of the subepithelial layer. This changes in the microvessels ranges between widening of these microvessels and also thickening of their walls. There may also be some extravasation of RBCs in the subepithelial layer, and in about half the cases there may be some inflammatory cells. The changes of the overlying epithelium are very nonspecific, apart from some thickening of the basement membrane, and occasionally hyperkeratosis due to the microtrauma, phonotrauma of the vocal folds that may give rise to white plaques over the surface of the vocal fold, but no dysplastic features are usually seen. Patients with even severe Reinke's edema may not have any specific complaint and may not seek medical help. The most common symptoms are deepening of the pitch of the voice, and although this affects both males and females almost equally, the females would notice that their voice is now being mistaken for a man's voice, particularly over the phone. They may also be effortful speaking due to the need to increase the subglottic pressure to drive vocal folds oscillation. Sometimes there will be inability to raise the pitch of the voice, and also some choking episodes in the severe cases. Also, patients may report symptoms of gastroesophageal reflux, which is a common association with Reinke's edema. The dysphonia in the Reinke's edema patient may be either to disruption of the mucosal wave or the effect of the deposits on the mass of the vocal folds. This would lead to lowering of the fundamental frequency down to perhaps 80 Hz in men and 110 or so in females. Some male singers may drop into vocal fry. Pain is a very unusual feature of Reinke's edema. In extreme cases, patients can describe dyspnea and even stridor, and there is a report of at least one patient who had tracheostomy due to the laryngeal obstruction by his advanced Reinke's edema. On laryngoscopy, the usual features are diffuse and sessile swelling of the vocal folds that can be asymmetrical and can be unilateral, but by far it's more common to be bilateral. The color of the vocal folds would be anywhere between grayish or yellowish, sometimes with a red hue if there is associated gastroesophageal reflux. The superficial blood vessels would be prominent, and sometimes there will be whitish patches over the vocal folds due usually to phonotrauma. Sometimes, although this is very uncommon, there will be dysplastic changes, and there have been few reports of carcinoma in situ as well. Last name, the vocal folds polypoid degeneration, perhaps refer to a subset of Reinke's edema, of untreated and chronic Reinke's edema, in which some changes had happened over the time, including things like increased submucosal fibrosis, thickening of the epithelium, and some fluid absorption. This would lead to multiple lobes along the entire length of the vocal folds rather than one large diffuse and sessile swelling, which is the usual typical picture of early Reinke's edema. In cases of unilateral Reinke's edema or asymmetrical Reinke's edema, there will be a greater vibratory amplitude and greater mucosal wave of the affected side. There will also be a slight increase initially in the subglottic pressure due to the need to increase the pressure to drive oscillation. The asymmetry of the vocal folds vibrations can be noticed, and sometimes this can lead to a disturbance in the periodicity. This disturbance in the periodicity can give rise to breaks due to the breakdown of the vocal fold oscillation. Several grading systems were suggested to grade the severity of Reinke's edema, mostly based on the size of the lesion. This real size of the lesion will be better judged during inspiration rather than during phonation. During phonation, the size can be underestimated as the lesion would tend to flip up and down the vocal folds or laterally towards the laryngeal ventricle. One of the common grading systems grades the severity into 4 stages. Stage 1 would only show marginal edema of the vocal folds, but on stroboscopy there would be a large amplitude of the mucosal wave. Stage 2 would show a sessile, clearly obvious sessile swelling of the vocal folds that is thrown over the vocalis muscle during phonation and have irregular mucosal waves on stroboscopy. Stage number 3 would have a large bag-like swelling filled with fluid, and the epithelial wave is difficult to recognize and have irregular amplitudes. The final stage, stage 4, would be characterized by partial obstruction of the airway because the medial borders of the vocal folds are now in contact along most of the airway. This can lead to dyspnea during exercise. The stroboscopic features are similar to grade 3, in which there is difficulty in recognizing the mucosal wave and irregular amplitudes. Another grading system is based on the extent of contact between the medial borders of the vocal fold. If it is less than 25%, it's grade 1. Between 25 and 50% of the airway, it's grade 2. 50 to 75, it is grade 3, and more than 75% of the airway showing medial contact of the two sides would be grade 4. Early and mild cases can be managed without the need for surgery by stopping smoking and voice therapy. Surgery should be considered in some occasions, including gross Reinke's edema causing choking sensation or airway compromise, in cases in which there is a leukoplakia or a whitish patch and a histological diagnosis is required, and in cases in which the patients are aware of their dropping in the vocal pitch and they require pitch elevation as their main reason for treatment. Other symptoms may not necessarily be helped by surgery, and there is always the potential for making the voice worse by causing scarring or anterior webs or irregular edge of the vocal fold. When discussing the treatment options with the patient should be informed that his voice would seldom return back to normal after surgery, but it would generally have a better quality. Still, his friends and relatives may not be able to recognize his voice, say, over the phone, and that the singing voice may be permanently changed. Speaking may be more effortful for up to 1 year sometimes due to the increased stiffness following surgery. This can be permanent if there is excessive mucosal resection of the vocal folds or scarring of the vocal ligament or anterior web formation in the anterior commissure area. The Reinke's edema is likely to return within 2 years if the patient continues to smoke. Principles for surgical intervention in cases of Reinke's edema. First, confirm that the patient had stopped smoking. This can be all what is required, plus some voice therapy in cases of early or mild Reinke's edema. If the patient has not stopped smoking and continued to smoke after surgery, it's likely that the edema would recur within 2 years. The operation itself is meant to reduce and debulk the size of the subepithelial deposits in a way that would cause the least amount of disruption and induce the minimum amount of fibrosis and scarring in the subepithelial layer. The vocal ligament should remain completely intact. Any injury to the vocal ligament, either surgical or overheating by lasers, can induce permanent voice changes. And the trimming of the excess mucosa should be very careful because excessive trimming can lead to stiffness of the vocal fold. The old way of treating Reinke's edema by stripping of the vocal folds is now obsolete. Reduction glottoplasty, or lateral chordotomy, or lateral microflaps, 3 names for almost the same procedure as first described by Herano almost 40 years ago. The surgery is started with an incision on the lateral part of the superior surface of the vocal fold. This can be done by laser sometimes or a sharp secant knife. Then the submucosal layer is entered. This is the superficial part of the lamina propria. You can see the deposits in here. This should be dissected off the vocal ligament to avoid any injury to this whitish structure, the vocal ligament. Then the material in there, the deposits, can be aspirated, sucked out, or removed by cupped forceps, or sometimes vaporized by laser. Then the epithelium will be redraped over the vocal fold to see if there is any excess mucosa that should be trimmed. And once this is achieved, then some injection of steroids in the vocal fold would tend to help in healing without too much fibrosis, and also the vocal fold surface can be sprayed with lidocaine to decrease the chance of laryngospasm on extubation. Remember that extensive resection would lead to more than average fibrosis and may not provide good post-operative voice results. The number 4 vocal fold benign lesion is arytenoid vocal process granuloma. The 3 common members of this group of granulomas over the vocal process of the arytenoids are granulomas following voice misuse or abuse causing phonotrauma, and granulomas following intubation, and granulomas following laryngopharyngeal reflux. There are also 2 less common disorders that we're going to touch on: the osteosclerosis of the arytenoid cartilage and the arytenoid cartilage rotation or malrotation in the case of vocal fold paralysis or vocal fold bowing. This group of disorders have a common pathogenesis. The key event is injury to the very thin mucoperiosteal layer over the vocal process of the arytenoid by a repetitive trauma or prolonged trauma. This is followed by ulceration and attempts at healing by secondary intention. And the healing is usually protracted and followed by proliferation of the granulation tissue with some epithelial hyperplasia. The injury, the mechanical trauma, can follow either intubation or from repeated impacts of the vocal process against each other during voice misuse or abuse, or during throat cleaning, coughing, or talking in a habitually low-pitched, creaky, hyperfunctional voice. This group of disorders are perhaps more appropriately termed arytenoid granulation tissues rather than granulomas. Unlike true granulomas, they don't have any giant cells. They are rounded mass of accumulated granulation tissue over the tip of the vocal process of the arytenoid, formed basically of capillary proliferation and fibrous tissue. They are covered by hyperplastic or metaplastic epithelium and ulcerated in parts. The pathology also includes a variety of acute and chronic inflammatory cells. Here are the three major subtypes of the arytenoid granulomas: the intubation granuloma, the contact ulcer and contact granuloma, and the granuloma following laryngopharyngeal reflux. The intubation granuloma can be characterized with a clear history of laryngeal intubation, injury, or surgery. The granulation tissues are florid, exuberant granulations forming a mushroom-like structure with a narrow pedicle. The contact granuloma starts with a contact ulcer, a whitish ulcer with an intense hyperemia at the edge of the ulcer itself, and it's usually painful. The ulcerated area would start secondary intention healing with granulation tissue that can form masses with different shapes like bilobed granuloma or cup and saucer type of granuloma. The history would include voice misuse or abuse, and it's predominantly a male condition rather than the intubation granuloma, which affects females more. The third type, the granuloma following laryngopharyngeal reflux, will be characterized by diffuse congestion of the larynx and the pharynx, perhaps with some interarytenoid pachydermia and little granuloma over a small ulcerated area on the arytenoid tip. We shall now go with more details on these subtypes in the next slides. The majority of patients with contact granuloma are middle-aged men. They form the granuloma secondary to vocal hyperfunction, although we'll discuss two situations in which vocal hypofunction can also lead to a contact granuloma. Patients would notice a change in their voice or symptoms of voice fatigue. They also describe early some sensation of a tickly throat, followed by a sensation of pain on one side of the throat that radiates to the ipsilateral ear. This pain is made worse on phonation, on clearing the throat, or on coughing. Some of them would have laryngopharyngeal reflux or gastroesophageal reflux symptoms like choking episodes. Almost always the lesion is unilateral, in contrast to chronic laryngitis, in which the symptoms are diffuse and sometimes bilateral. The onset of the symptoms can be gradual, starting with a tickly throat, proceeding to pain and worsening of the voice, or it can be abrupt following some change in their circumstances, like a period of stress or travel, or after upper respiratory tract infection. The voice of contact granuloma patients would be strained due to the hyperfunctional nature of their voicing, but it may also be a bit breathy because the granuloma may interfere with complete glottic closure during phonation. It would have a rough quality, and characteristically there would be a low pitch voice, sometimes a vocal fry quality. The dynamic range of the voice would be limited and the voice would be monotonous. The patient would speak in short sentences at the end of a short breath. Stroboscopy would show a longer contact phase. Laryngeal examination in arytenoid granulomas are better carried out with the use of a rigid 70 degrees or a 90 degrees telescope, because they would help in showing the early subtle changes in the vocal process of the arytenoids, like some congestion or some small ulcer before the granuloma itself forms. The endoscopic features of the granuloma can be seen on laryngoscopy, together with features of hyperfunctional voice, like shortening of the anteroposterior dimensions of the vocal folds during phonation, and also attempts of the ventricular folds to adduct during phonation. There will also be lack of cricothyroid activity with cricothyroid membrane lock during phonation. Contact granulomas usually form with hyperfunctional voice disorders. But here are two examples of hypofunctional voice disorders that may cause contact granulomas. One is vocal fold paralysis, the other is vocal fold bowing in the elderly. In vocal fold paralysis, the arytenoid on the paralyzed side would rotate forwards and medially. It would not be on the same level with the mobile arytenoid. Some patients used to compensate for the hypofunctional voice by forceful adduction or attempts at forceful adduction. The mobile arytenoid would hit the arytenoid on the paralyzed side at a higher level because they are no longer on the same level. And the site of collision may actually be higher up in the arytenoid body of the paralyzed side, or even in the corniculate or the cuneiform cartilages of the paralyzed side. This is where the ulcer is going to form and the contact granuloma is going to form as well. And the other example is the vocal fold bowing in the elderly, and again something similar is going to happen. Some patients will try to compensate for their hypofunctional voice by forceful adduction, causing the collision of the two arytenoids, which because of the changes in the vocal folds in the elderly would be more skeletonized and more prominent, and this is going to form a contact granuloma. To treat these two conditions, the patients may require laryngoplasty or thyroplasty to close up the glottic gap during phonation, combined with arytenoid adduction procedures to correct the problem with the levels of the arytenoid. The second subtype of arytenoid granulomas is the intubation granuloma, caused by localized injury to the mucoperichondrium of the vocal process of the arytenoid from the intubation or from laryngeal trauma or surgery. In contrast to the contact granuloma, which has wide base, here the base would be very narrow. It will be a pedunculated mushroom-like granuloma with a narrow pedicle. It's usually unilateral, but it can be bilateral as well due to the pressure of the tube on the two sides. And other lesions may form in addition to the contact granuloma, like small cysts lined by squamous epithelium, again on the tip of the arytenoid process. Intubation granulomas, in contrast to the contact granuloma subtype, affects females more than males. The smaller female larynx makes it more susceptible to injury by the pressure of the endotracheal tube, particularly if it is left for longer periods. The ulcer on the tip of the arytenoid process can be made worse with the effect of laryngopharyngeal reflux. These patients describe voice disorders in the form of dysphonia or even aphonia, but again, in contrast to the contact granuloma, they don't describe much pain or irritation in the throat. The intubation granuloma can reach a large size. They are pedunculated and are mobile and can form a ball valve that can partially obstruct the laryngeal airway during breathing. Third subtype of the arytenoid granulomas are those associated with laryngopharyngeal reflux. Laryngopharyngeal reflux can affect children or adults. It can give rise to acute symptoms, chronic symptoms, or intermittent form of laryngitis. These can cause inflammation of the arytenoid, sometimes with ulceration, with or without granuloma formation. The characteristic feature is the diffuse nature of the condition that affects most of the larynx and also the hypopharynx, can give rise to interarytenoid pachydermia and a small amount of granuloma on the arytenoid cartilage. The irritation and the inflammation of the larynx with laryngopharyngeal reflux can give rise to frequent attempts at throat clearing or cough or occasionally laryngospasm. All these can add to the injury to the vocal process of the arytenoid during repeated adduction and can give rise to a small ulcer and a small granuloma on the tip of the arytenoid process. The presenting features for this condition would be the throat irritation, a global sensation, and frequent cough. The changes in the voice may be secondary to the presenting symptoms of throat irritation. The main lines of treatment for arytenoid granulomas include things like reducing the effect of laryngeal irritants, stopping the smoking, improving vocal hygiene, treating any respiratory tract infections or allergies, and control of laryngopharyngeal reflux. Voice therapy is also a mainstay in the management of arytenoid granulomas, with raising the awareness of the condition, reducing the hyperfunctional element of the voicing, and preventing any voice misuse or abuse. There is no good evidence to support the use of antibiotics in general, only in very selected cases where chronic inflammatory processes in the cartilage are suspected. Symptoms may improve by inhaling steroids or even systemic steroids, again in selected cases. Nebulizers can decrease the throat irritation. Surgery in the form of microlaphryngosurgery should be a last resort in the management of arytenoid granulomas. Surgery alone does not cure arytenoid granulomas, and there's a very high chance of a recurrence. But surgery is helpful in confirming the diagnosis and excluding a sinister pathology, and can also be helpful in debulking a large lesion that may threaten to compromise the airway. If surgery is chosen, then lasers usually gives a better success rate, and they also reduce the amount of bleeding from these vascular lesions. Care must be taken to avoid any thermal injury to the underlying cartilage during vaporization of the lesion. A pulsed laser, sometimes dye lasers, has been used with success, and following the removal of the granuloma, one may consider the use of local steroids or even mitomycin to help in preventing a recurrence. There is also a need to consider the use of Botox injection in the thyroarytenoid muscle, a small amount like 5 to 8 units, to reduce the impact of the adduction that may help in the recurrence of the granuloma. And finally, number 5, the vocal folds cysts. Vocal fold cysts are true epithelial-lined cysts within the lamina propria of the vocal folds, in contrast to vocal nodules that arises from microtrauma to the basement membrane of the epithelial cover of the vocal folds, or polyps that arises following microvascular injury and leakage into the superficial layer of the lamina propria followed by the formation of the polyp. The cyst would cause dysphonia primarily because of the mass effect in the superficial part of the lamina propria. This mass effect will cause irregularity in the vibratory pattern of the vocal folds during phonation. But also, vocal fold cysts can prevent adequate closure of the vocal folds during phonation and can cause compensatory increase in the tension of the vocal fold muscles, and can also cause increase in the stiffness of the vocal fold because they lie deep to the basement membrane and can stretch the basement membrane of the vocal folds. They have viscoelastic properties different from the rest of the superficial part of the lamina propria, and that would give a diagnostic characteristic features on stroboscopy. There are two primary types of vocal fold cysts. The commonest is the mucus retention cyst, which is mucus-filled and lined by glandular epithelium. It arises from a blocked minor salivary gland secondary to either phonotrauma or inflammation. The other type is the epidermoid cyst, which is keratin-filled and is lined by squamous epithelium. Again, it follows phonotrauma, either vocal abuse or misuse, in the presence of some aggravating factors like inflammation, smoking, laryngopharyngeal reflux, or it can arise due to congenital anomalies. The mucus type cyst is far more common than the keratin cyst. Patients usually have a history of phonotrauma in the presence of some aggravating factors like, for example, laryngopharyngeal reflux, and this would give a higher risk for the development of these mucosal cysts. They arise from blocked minor salivary glands found usually on the undersurface of the vocal folds closer to the edge of the vocal fold, usually affect only one lip of the vocal fold edge, either the superior or inferior. They are different from the keratin cysts by color. For example, they are yellowish to amber in color. in contrast to the whitish keratin-filled cysts. And because they can be translucent, they can sometimes be confused with vocal fold polyps. In contrast, the epidermoid keratin cysts arises from micro-inclusion of tiny islands of squamous epithelium from the surface of the vocal folds under the surface of the vocal fold due to either trauma or phonotrauma. Or they can arise from metaplasia in a long-standing mucus retention cyst where the glandular epithelium is metaplastic to squamous epithelium. They can also arise from an existing sulcus that has its opening closed by scarring, or by a defect in the epithelialization of the vocal fold during development, and this will give rise to the congenital keratin cysts. They are filled with cheese-like epidermal debris and keratin and give a whitish pearly color, usually on the surface or close to the superior edge of the vocal folds. Vocal fold cysts presents with dysphonia. This may be very mild or subtle in the early stages of the cyst formation, but with progression in the mass and the incomplete closure of the vocal folds during phonation, things like roughness of the voice and occasionally a strained voice due to the increase in the subglottic pressure would be noted. This would give rise to fatigue, voice fatigue. The fundamental frequency will be reduced due to the mass effect, and the voice fatigue will all be associated with effortful phonation. Also, it would be noticed that the pitch range has reduced, particularly towards the upper part of the range, and possibly there will be sometimes complete voice breaks due to the irregularity in the vibratory patterns, the asymmetry between the two sides during phonation. The stroboscopic features are reduced vibratory stability. You could see that there is a reduced amplitude and range of the mucosal wave over the vocal fold with the cyst in comparison to the contralateral vocal fold. And there will be no mucosal wave in the cyst area. It may sweep around it, either superior or inferior. And this is a distinguishing feature, stroboscopic feature of a cyst in contrast to a polyp. Because the cyst lies deeper in the lamina propria, there is usually no mucosal wave over the cyst area itself. Vocal fold cysts can coexist with either a vocal fold sulcus or a vocal fold mucosal bridge. This is because these conditions share overlapping etiologies and can often be related to the same factors like either phonotrauma or congenital factors. The combination of vocal fold cysts and a sulcus or a bridge would worsen the dysphonia as expected and also complicate the management plan. The cyst may form close to a sulcus due to trapped mucosa and to the associated phonotrauma, and a sulcus on its turn can follow a rupture of an epithelial-lined keratin vocal fold cyst, and if this cyst rupture has two openings, it may form a vocal fold mucosal bridge. We now move to the management. Conservative management may be tried first. Small cysts may partially respond to voice therapy. This may reduce the hyperfunctional muscle tension, compensating for the mass loading of the cyst. The cyst itself should not be expected to disappear with voice therapy. Voice therapy and voice hygiene and control of things like reflux have limited success rates in resolving the cyst itself. It would have partial relief of the symptoms, but whereas voice therapy can lead to regression in the case of vocal fold nodules, they are not going to cause this with vocal fold cysts. the ultimate management will be microlaryngoscopic excision. Microlaringer operation is started by an incision parallel to the vocal fold edge, a lateral incision, to create the microflap. This would include the epithelium overlying the cyst itself. Dissection then proceeds in the superficial layer of the lamina propria, preserving all this normal epithelium and exposing the cyst itself. The cyst would then be removed. Every attempt should be done to remove the cyst in one piece, but if this is not achieved, if it punctures, then every attempt should be made to remove all the remnants of the cyst, otherwise recurrence rate will be quite high. After excising the cyst, the microflap can be reposed in position, and an installation of local steroids can be useful to decrease the post-operative edema. By this, we come to the end of this presentation on the commonest 5 benign vocal fold lesions. This is part 1 of 2 lectures. In part 2, we shall discuss other benign vocal fold lesions, including things like vocal fold pseudocysts, sulci, the mucosal bridges, and the abnormal blood vessels patterns and vascular anomalies in the vocal folds. Assalamu alaikum.